Thank you, Dr. Allen, for including me in this course. The history of intraocular lens dates back to 1949 when this gentleman first implanted the lens, but he had a huge refractive surprise of 21 diopter. We understand that the technology and everything was very primitive at that point of time. So with the advancement in technology, not only the machine which could calculate the intraocular lens very correctly, but the IOL formula and the machines which we are operating upon and the training of us led us to become a very proficient surgeon and to give a best outcome to our patient. But no matter how, whatever you do, there are some situations where we get some refractive surprises which can lead to dissatisfied patient, particularly once you have implanted some premium lenses. So all precautions has to be taken to prevent its occurrence as well as to diagnose and manage it effectively at particular point of time. So prevention requires more consistent method of biometry in intraocular lens formula. So I won't go into that detail. It has already been dealt with. But one most important thing is prior refractive surgery. I do get some patients referred from here and there who had undergone some LASIK procedures and now came with the intraocular lens implanted with refractive surprise. So another important things which I have noted that there are sometimes typographical error which can lead to post-operative refractive surprise, particularly in the toric lenses, where the person has actually put the data 90-degree opposite to that. There can be some IOL mislabeling sometimes and wrong IOL in wrong patients. So what to do once we encounter these situations? You must look for the cause, what went wrong, check all the data, and in the immediate post-op days, we can sometimes find capsular back distension syndrome, particularly in the plate haptics IOL. So you have to dilate and see whether there is any fluid behind the lens or not. And in RK patient, you have to actually wait for the refraction to be stable. So what you are going to do, if the patient you have to know what is the patient expectation. Sometimes patients may be happy, but you are not satisfied. So don't let the patient be unsatisfied by telling that you have this much of refraction, which we did not expect. So if the patient is asymptomatic and very much satisfied, just simply observe. If the patients are ready to wear the glass, small amount of some refractive surprise, give the patient a spectacle, and contact lenses if the patient is used to and if there is high degree of anisometropia. And there should be frank discussions with the patient regarding the source of this error, and once it is known, how to correct it. The patient who desire actually spectacle independence, discuss them the risk of the further surgery, because sometimes there may be some chance of losing some vision, particularly the risk of infection is always there. So they have to be told about the risks which are often greater than the primary surgery. So there could be two ways by which we can correct this surprise, like lens-based approach, like IOL repositioning, IOL exchange, piggyback IOL, and cornea-based approach, that is the laser vision correction. So IOL repositioning, particularly in the toric lenses, I have hardly re-rotated the patients in the normal cases, but I have rotated in 3-4 patients where the data was actually misfed and the 90-degree in the opposite direction. But it can happen, so one has to take all the precautions, and it has been rightly dealt by previous speaker how to take care of that. So the advantages of the lens-based approach is that original carotid wound can be opened and you can go through that, and there is high degree of spherical aberration which cannot be corrected by the LASIK procedure. You can do with the lens exchange, and it does not alter the corneal architecture like in the LASIK. At the same time, there is no need of special settings. So one can very well do that. So in IOL exchange, if the problem is significant or the problem with the IOL, and these patients can be subjected to IOL exchange, but again, it is less predictable than the piggyback and the laser vision corrections. And the chances are there strong adhesions in patients who are coming late. So in those patients, you may not be like to put that lesson. This is one small video clip when it is quite old, more than 20 years old, when I this was my first RK patient who had developed actually cataract and came to me, and I did not have much idea how to go deal these patients, so I landed with the refractive surprise. After having waited for 2 months, I explanted the lens. Since the number of incisions were less, so I could go through the limbal incision, otherwise I could have gone through the sclera. So this was one situation. Another very interesting situation, that one of my patient who wanted to go distance free intraocular lens implantation landed with the surprise of 5 degree. And when I reviewed what went wrong, I could see that the patient actually, this is the IOL Master 700. Patient was not actually focusing. You can see the tilt, so the graph was not good. That's why the patient had calculation of the axial length, which was much less. So when I did that, you can see the IOL here. The actual axial length was actually less, so more. So I had to explant this lens and then put a 10 diopter lens. This was a toric lens implantation, and before this time I did not have Callisto, so I was using the manual marking. So once you are planning to do IOL exchange, you have to inflate the capsular bag and the anterior chamber, good viscoelastic, viscodispersive. I prefer using viscot so that you don't injure the endothelium. Then disengage the lens from the capsular bag, take out into the AC, and what I do that I implant the next or the desired lens in the bag before I take out the lens, so as to give a scaffold to the lens and to prevent the posterior capsule by abundantly injuring with the vanas or any other scissors which you are using to cut the lens. So here I am just rotating I have rotated the lens and taken out in the anterior, and now I am taking out the haptic and holding the haptic. I am again using the viscot. I am using the Ausser cutter. You may not need to go complete, even half. If you go to half distance, it will roll out the lens through 2.8 or sometimes 3 millimeter of incision. So this is one of the method of taking out the lens, that you need not cut it completely. So another option is the piggyback lens. When the surgery has been quite long back, and there is strong capsular adhesion, and you think that there can be more injury if you try to free the lens from the capsule, then it's a better option. So it's effective, safe, and easy. Here you implant a lens into the sulcus, over and above the posterior lens, chamber lens, which is all there in the back. The only thing is that it sometimes can cause some pigment dispersion or other things, but the Indian lenses are available from the care group. I don't have any financial interest. And the power of the piggyback lens, it's easy to calculate. If there is hyperopic error, you multiply the lens spherical equivalent with 1.5, and for myopic error is multiply it with 1.2. This is one small video clip. This was 30 years old made. Actually, this was a case of pediatric cataract which was done when the person was 10 years old. Then he came to me with so much of the refraction. The same thing can be extrapolated actually in the adult onset cataract surgery with refractive surprise. This is one of the Indian made lenses, add-on lenses, came by the name of Sulcofix. The prototype is Sulcoflex from the Renner. So I have no experience of using that. This was a toric. So its implantation is very easy. It doesn't take much time, and this patient had actually YAG laser also done. So that is the advantage of using piggy back lenses in situations where you already have posterior capsular dehiscence or any PC capsulotomy done. Then this is a better option than going for the IOL exchange. So laser vision correction is another good option, but it can be reserved for a small amount of refractive error, but it requires extra machines and extra cost. So if you have this machine, you can offer to your patients. PRK is preferred over LASIK because here, since most of the patients are old, so it doesn't compromise with the tear film. But if you are doing this, better to wait for 3 months, let the wound stabilize. And there was just one study which clearly said that the LASIK is the most accurate procedure to correct the residual refractive error after cataract surgery. Of course, it cannot go up to very high, and you have to see how much the cornea, the thickness is there. This was one of the 43 years old female patient operated 2 years back with vision of 660 and had a refractive error of this much. So since the corneal thickness was very good and patient agreed to go for the LASIK procedure, so I resorted to this procedure for this patient, and patient was very happy after the surgery and could achieve 6/6 without any problem. So that is one of the best way of correcting, giving almost 6/6 vision to this patient. So just to summarize, refractive surprise can occur no matter how much careful you are, how much new machines you use. Particularly in predisposed eye, look for the cause. Give the options of using glass and contact lens. If they don't go for that, then you can use these procedures to uh, correct the refractive surprises. And IOL exchange piggybacks are reserved for the big surprises, but you can go for the laser vision correction for the small refractive surprise. Thank you so much.
Wonderful lecture, sir. So I would like to ask, sometimes, many times when we get the lenses for some toric lenses, for example, like 21.5 diopters, and it shows residual refractive error would be plus 0.25. In some, if we get 20.5, we get minus 0.25 or 0.75 of the refractive, because we don't get uh, in odd numbers. So what would be your choice for toric lenses in like residual refractive error of plus diopters or in myopic diopters?
Sir, actually, we expect that there will be some amount of, by definition, refractive surprise is told once you have 0.75 diopter mode of astigmatism after surgery and 1 diopter of spherical after surgery. So, I could not get your question. How much you?
No, sir. For example, if you, like lenses available for you, for example, they give the, we calculate and we send the patient for some calculations, and if they say that with 21.5 diopter you will have residual refractive error for such patient like minus 0.25 diopter in plus, in minus, and with 22 diopters it will show plus 0.25 residual diopter. So what would be your choice? Whether you'd go for the myopic residual refractive error for that lens, or
I would go for myopic.
right.
I think what we can do is we can type of refraction. Young patient with the rule go to the plus side, and old patients against the rule, because you don't expect much changes going forward.
Yes, very
You
true,
be on target. Whatever the least astigmatism you go. But young patients with the rule, you always have to go to the plus side, because after some time the ATR kicks in. As you age, the ATR also kicks in, so that will
Right,
to some
sir.
extent neutralize that.
And also, I think minus refractive error or residual refractive would be better tolerated as compared to
Yeah, that's okay.
hypermetropy.
These with the rule, young patients, I think going to the plus side.
Plus side more.
Yeah, agreed.
Yes.
One
No,
thing.
I agree with the minus part of it. The reason is, if you go to the plus side, it will flip the axis. That patient is going to be very unhappy.
Unhappy.
Very unhappy. Little bit lesser is little bit.
One thing just I want to mention that in RK patient who had developed this postoperative refractive surprise, piggyback lens is always better, because here you can calculate the power, and if you just exchange the lens, even then you are not sure how much it's going to be.
One more innovation I want to add, sir. Dr. Neha Dolakia has brought about
Yeah,
a lens cutter.
Yeah.
Beautiful. Just 12,000 rupees. Indian innovation. Chamber doesn't shadow.
Yeah.
We need not have to use the
No,
scissors.
I have stopped using this saucer.
Yes, sir.
Yeah, ultrasound tip, no?
Ultrasound tip. Ultrasound tip.
It will solve major problems.